Right, welcome everybody to the BCP Council Health and Wellbeing Board this afternoon. We'll go straight into it. We've got quite a few items on the agenda today, but I do hope to cover everything off within about 2 hours by 4 o'clock. But yeah, don't want to stifle discussion or debate. But yeah, the timings we've got, we should be able to do that like we normally do. Right, if I could just firstly ask our Democratic Support Officer to read the housekeeping notice.
Thank you, Chair. Please note that this meeting is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair. For those in the room, please note if a fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the assembly point at the War Memorial in the gardens opposite the front of this building. Finally, please ensure background noise is kept to a minimum. Mobile phones and other devices are turned off or switched to silent for the duration of the meeting. For those in the room, this includes turning off microphones and turning down the volume on your laptops completely. Thank you.
Thanks. Right. I will now move on to the next items on the agenda, apologies and substitutes. After we've done apologies and substitutes, I will go around the room just to ask for introductions, because there's always a few different people that are normally here, and also we've got our new corporate director here, so it'd be useful for her to be introduced to everybody. So, so apologies first.
Thank you, Chair. We've received apologies from Kathy Hadley, Dawn Dawson and Siobhan Harrington.
Okay, any substitute members?
Yeah, Rachel Gravitt is substituting for Kathy Hadley, Ellie Lindop is substituting for Dawn Dawson, and Lizzie Warrington should be joining us online, and she will be substituting for Siobhan Harrington.
Right, okay. I will go around, we'll move on to election of vice chair in a moment, which I'll just cover, but yeah, we'll go around the room, just ask for introductions. So if I can start on my left, well, we've got Louise as our Democratic Support Officer.
Yeah, hello, Councillor Richard Burton, portfolio holder for Children, Young People, Education and Skills.
I've just sorted this out as well. Councillor Sandra Moore, portfolio holder for Communities and Partnerships.
Emma Senior, Commissioning Manager for Prevention and Wellbeing in Adult Social Care Commissioning.
Scott Saffin, Better Care Fund Manager.
Afternoon, Zina Dighton, Director of Commissioning Adult Social Care.
Hi, I'm Betty Beltlin, Director of Adult Social Care.
Rachel Gravitt, Director of Commissioning Resources and Quality Children's Services.
Ellie Lindop, Deputy Director of Nursing Therapies and Quality in Dorset Healthcare.
Karen Loftus, Chief Executive, Community Action Network.
Good afternoon, Pete Browning from Dorset Police.
Good afternoon, Mark Harris, Deputy Director of Place for NHS Dorset, deputising for David Freeman, who sends his apologies.
Afternoon, everyone. I'm Laura Ambler. I'm the new Corporate Director for Wellbeing in BCP. Nice to be here.
Hi, everyone. I'm Rob Carroll, Director of Public Health and Communities.
And I'm Aidan Dunn. I'm the Chief Exec of BCP.
Thank you. And we've got a few people attending online. I can start with Kat, actually, if you can.
Good afternoon, everyone. I'm Kat McMillan. I'm Head of Communities, Partnerships and Community Safety at BCP Council.
And Rebecca.
Hi everybody, I'm Bex Kendall. I'm the Deputy Director of Performance and Planning at Dorset ICB, and I've joined for the agenda item on the commissioning plan.
And Dylan as well.
Hi all, I'm Dylan Champion. I'm the Programme Director for the Future Care item, and I'm here to give the update.
Thank you. Welcome all. Thank you for coming along this afternoon. It's nice to have a good turnout again, actually. Right, the next agenda item we have is for election of Vice Chair. As you'll recall from the last meeting, so we have a vacancy for Vice Chair. I don't know if anybody, I've had conversations with a couple of colleagues. We could go through, I think, meeting later in the year, we'll have a sort of formal election of chair and vice chair. So it would only be for the remainder of this meeting. Well, as a colleague pointed out, I could be taken ill during the meeting, so we might need a vice chair. I'm not planning to. And I think it's just for the one next meeting. I don't know whether often it's worked well with having a health partner in the vice chair position, and I don't know whether we wait for things to settle down with sort of ICB colleagues before we sort of plan that for later in the year, and we could just continue without a vice chair. Or any thoughts or comments? Or
yeah, I guess, I mean, obviously there's lots of changes going on in the ICB at the moment. So, I mean, if it's for one more meeting for this end of this financial year, then I guess I could put myself forward if that's acceptable. I think it would make sense to review once we've got the formal executive in place for the ICB, the new cluster ICB, which hopefully will be announced in the next couple of weeks.
Yeah. Okay, I think that sounds reasonable to me. I think it's just for the remainder of this meeting and the next meeting we have the vice chair. Then we have the sort of annual meeting where we elect chair and vice chair for the following municipal year. And the timing of that probably works quite well, and we know where we are with the ICB cluster. So if you're happy, I'll propose Mark to be vice chair for until the next annual meeting. Have we got a seconder for that?
Yes, I'm quite happy to second that, Chair.
Thank you. Is everybody content with that? No disagreement? Okay. Thanks for that, Mark. I'll try not to fall ill in the next 2 hours. Should be all right. Okay. The minutes of the last meeting on the 6th of October. Has everybody had a chance to have a look through them? I've had a bit of a look through them. Any comments or amendments or points on the minutes from the last meeting in October? No? Okay, is everybody happy if I sign that as a correct record of that meeting? Okay, thank you. We'll do that. Agenda item 5, declarations of interest. Any committee member got any declaration of interest, please indicate now, or if anything crops up during the meeting, feel free to let us know. No? Okay, thank you for that. No declarations. Item 6, public issues. Are there any public issues for this meeting?
There are no public issues, Chair.
Great, okay. Thank you very much. So we can go straight on to agenda item 7. So this is the mid-programme review for the Future Care programme. So I think you'll all probably be familiar with the Future Care. We've got Dylan Champion, the programme director for the Future Care programme, online here to present the report. So yes, over to you, Dylan.
Thank you. If I can just share my screen. I don't know whether Betty's in the room and she wanted to give an initial introduction.
All right, Betty, did you want to?
Yeah, hi Dylan, I am. Nice to see you and thank you for joining us. So yeah, the Future Care programme is a programme that is focused on urgent and emergency care. It's an ambitious programme that has now been running for over a year following a diagnostic that took place within the Dorset County Health and Social Care system. Our strategic partner who is working with us on the Future Care programme are Newton Europe, and they've been involved in this with us for over the last 15 months or so. It's an ambitious programme. It is all around positive outcomes for our residents. And the first phase of it initially was focused on how do we improve discharge and how do we improve flow within our acute and community hospitals across Dorset. The programme has got a number of work streams that Dylan will share with the board, and it has a number of SROs that are senior leaders across our health and social care system who undertake those roles and functions of being the senior reporting officer. I'm one of those in one of those programs. There is clear governance structure already established for the Future Care Programme because there's a lot riding on it and there's a big commitment from all system partners. And within BCP Council, our governance structures for it are via Cabinet and via Health Overview and Scrutiny Committees. And of course, Health and Wellbeing Board are interested in understanding and seeing the benefits, and hence why, after discussion with David as chair, it was agreed that it would come to this board today. So I don't want to steal any more of Dylan's thunder, but we recently brought this to our ONS Health Overview and Scrutiny not that long ago, so it's kind of following that process and that path. And then very happy to take any questions with Dylan at the end of it. Thank you, Chair.
Thank you.
Thanks, Betty. And hopefully colleagues in the room can see that I'm sharing a presentation, which I'll go through quite quickly because I'm aware that a lot of people are already quite familiar with the Future Care programme. But just sort of providing an overview. So the purpose of this report is there's a similar, if not identical, report being presented to each of the Future Care partners, and it provides, amongst other things, an update on where we are at the sort of midpoint of the programme. Now, formally, the midpoint of the programme was at the end of October, and so some of the data referred to in the report relates to the period up to October. We are getting data from the period up until the end of December, but that's still being validated. But the purpose of this report is primarily to provide the board with an update, and a similar process has been taking place with other partners as well. So moving on and just picking up on what Betty was saying, the programme is structured around 4 key work streams, and those 4 key work streams are alternatives to admission, so preventing people that are presented at the emergency department of acute hospitals needing to be admitted into bedded wards is one of the key work streams. The second is looking at transfer of care processes and how different organisations, including both local authorities and the providers, work together to help people to get home quickly. The third work stream, and it's the work stream which is being led by BCP and in particular by Betty, looks at home-based intermediate care and the services in place to help people to get home from hospital and to be supported at home following a hospital stay. And the fourth work stream looks at bed-based intermediate care. Now, bed-based intermediate care combines the support provided in community hospitals, but also the short-term support provided in some care homes, and in particular within the BCP area, Coastal Lodge and also Figbury Lodge. So that's the scope of the programme, and the aim of the programme is to provide better outcomes for people, to reduce hospital pressures, to improve hospital discharge, to reduce long-term care needs, and to support more people to recover at home. So picking up the sort of key sort of headlines from the mid-programme review, what the mid-programme review identified was that the programme was sort of on track against its trajectory at the end of October and against its projected delivery of benefits of £12.9 million, sorry, against its target of £12.5 million at the end of October. Where we were was at £12.9 million, so on target. And I think the second key thing to note is in terms of the benefit flowing to BCP Council, that was also sort of on target by that point, and also moving into the positive in terms of net benefit delivered within the day. There are also real achievements for people that have been achieved by that point, and in particular around intermediate care beds and people staying in hospital for 5 days less and getting home sooner than at the beginning of the programme. And also more people each week, 80 people more each week, being supported through same-day emergency services within hospitals rather than being admitted into bedded care. So what we could see at the midpoint was some quite significant benefits for people, and also some benefits within particular organisations. There are also some real challenges at the midpoint, and those challenges continue. And the sort of biggest challenge at the moment is around reducing the average length of stay for people waiting to get home out of UHD hospitals. And here we've got quite an ambitious target as a programme, and that's to reduce that length of stay to 8.1 days. There's partners are working really hard at the moment to reduce that, and there have been pressures through November and through December, but the work and the actions are in place to ensure that does begin to come down, not least because good progress has been made with home-based intermediate care and increasing the amount of flow and the effectiveness of reablement services across Dorset, but particularly within BCP. The improvements following those challenges, and I picked up on some of those, the sort of big one is that the number of weekly discharges from UA, or complex weekly discharges from UHD hospitals, was consistently sort of increasing in the weeks before Christmas. There's been a challenging period in the last 2 weeks, but what we expect is that positive trend that we were beginning to see through the back end of November and December begin to re-establish itself in January, so that those discharges increase and those better outcomes for people occur. So there are things that are positive and improving since the mid-programme review. January is going to be really important in terms of tracking that and delivering that, but as a programme we're confident that they're the right things. Earlier in the presentation I talked about the impact that the programme is having on people and individual outcomes, and what we've got on this slide is some of the sort of very personal examples of how the programme and the different ways of working are actually making a difference to people and real experiences within Dorset. So that's all I was going to say in terms of a sort of introduction. Very happy to take questions or observations, but this final slide sets out the recommendations within the report, which are to recognise the progress made, but also to note that more work is required to reduce the average length of wait for people, particularly coming out of UHD hospitals. Thank you, Chair.
Yeah, thank you for that, Dylan, for that sort of quick run through to sort of get us all up to speed with where things are at the end of the first year. Any questions or comments or points that anybody wanted to raise? So I think the recommendations are fairly straightforward, but yeah, is there any questions? Betty, I'll let you.
Yeah, I feel like I just want to support some of what Dylan said, and just to reinforce the amount of work that's gone into this programme. It has taken such a long time to get us to where we are, and a huge amount of infrastructure that has come both from the programme team and all system partners, but also from our strategic partner as well. And I think one of the key things for us is going to be the next 6 months, because our kind of work with Newton, if you like, even though there'll still be in-reach work and there'll be lots of contact still after the summer, but technically our time with Newton should draw to a conclusion or an end, and then just seems very final, and it won't be that final because we'll still have that contact in those dreams and abilities to go back to them. But we are on the kind of last 6 months, if you like, of the programme's implementation. And it's really important that the committee are kind of aware of that and sided on that, because of course we all know that time goes so quickly, doesn't it? You know, you're in 1 month and then you're into the next before you blink. I guess that's the one thing, Chair, that I think is really critical to point out. We are now on our downward trajectory of the programme and its completion, particularly with our Newton colleagues. Thank you.
Thanks for that, Betty. Any other comments? Laura, did you want to?
Yeah, I guess that's helpful framing, Betty. Thank you for that. So on that, I think what would be helpful to know is when the programme reaches its conclusion, how we're embedding it into BAU, because I think that's what's coming out here, isn't it? So particularly I'm thinking that home-based intermediate care programme that you're leading on, the intention is to embed that into BAU so it becomes something that is then far more sustainable. So maybe we just need to be explicit about that and what some of the actions might be. And then linked to that, I was just wondering if there's some benchmarking that we could do. And maybe, Mark, that's one with colleagues from the ICB as well. Just looking at, I'm thinking community length of stay, not just acutes, for example.
Shall I come back? Yeah, no, that's helpful, Laura. There is a very clear programme of intent around how things are beginning to become business as usual now. That's all factored into the programme and the overarching day-to-day running of the programme, if you like. We have a focus on communities as well that is part of the programme, and that's already embedded within alternatives to admissions and how we work with primary care and all of that kind of stuff. So there is a lot already within the programme that is already there, and some people, you know, particularly people that are new to our system, you know, we just need to take time with you to kind of understand that and to share that. But I'm confident that it's all that infrastructure is already there. I think so. I think as individuals rather than as a system, as individual organisations, we'll have to be satisfied that we have our own internal arrangements to make sure that we have infrastructures in place so that when our Newton colleagues go, that we don't miss them. And that was always my very first thing whenever we were with Dylan Smiling, because I must have said it to Newton that many times. I don't want to miss Newton when they go, as lovely as they are. And it's about, for me, it's more about internal organisations, making sure that they've got their infrastructure, strategies and processes in place, particularly around digital and information and informatics and all that stuff with ICT colleagues, and we're working on that. Yeah, thank you.
Rob, did you want to?
Yeah, I think, you know, just to recognise the huge amount of work that's taken place during this programme across our system partners, really difficult but important work, and great to see the benefits are now being realised both in terms of system flow, the finances, but more importantly, outcomes for residents as well. And in terms of a question, just wondering, we've had a difficult winter so far in that it's probably started earlier than usual. I'm just wondering what impact is that having currently on the programme, and how do we accommodate that in terms of our trajectories going forward? And, you know, realising it's kind of beyond control of the system in many ways. Thanks.
Yeah, Betty.
Dylan, I'm helping out a lot here. Don't forget this. I think
happy to take that unless you want to take it, Betty.
If I'll give a bit of a recap of what we did and then you come in. So I think it was this week, because we're back into the new year, we're back into our structured programme of work as SROs. And we had a future care meeting on Thursday just gone, and that is very much about reflecting over the winter period. And now we know we're in a really bad winter period at the minute, you know, not least of all, you know, flu and all the associated stuff, you know, that comes with that. We know that our hospitals are really under pressure, and that our bed capacity is stretched to its optimum level and more. So we have been tracking and monitoring things really closely. We put different infrastructures in place over the winter, and we're about to implement some of those. What Future Care has been able to do is to really help us to understand our data better and to provide one version of the truth through the mechanisms that they've been able to develop with us as a system rather than individual organisations. I would say the Future Care is not there to help us manage our business as usual. It's there for a transformation programme that is going to bring around sustainable change over a period of time. But what it absolutely does do and does assist us with is being able to identify those hotspots, those areas of focused, and all of the work that we're doing within the 4 subgroups within the programme, such as intermediate care, reablement, alternatives to admissions, our cohos, our bed capacity, really enable us to be able to use all of that intelligence, all of that learning and all of that progress into business as usual. So it complements it naturally, but it isn't there to do business as usual. It's there to do big transformation work, but they both work hand in hand. I don't know if Dylan, Chair, wants to come in and add anything.
Yeah, Dylan, you got anything to add?
Just 2 very quick things from a relatively external perspective, and not someone that's been in Dorset very long, and reflections on the sort of Dorset response to winter pressures and the impact of Future Care on that. So in the week before Christmas, BCP and colleagues in the East and UHD achieved 103 P1 or home discharges out of the hospitals, compared to a normal week of 62. And in that week there was a total of 148 complex discharges in the week before Christmas. Now, having worked in a lot of systems, that number of people going home and that an amount of coordinated support is something relatively unique at that scale. And I think that's sort of a product of how well Dorset partners are sort of working together, both around Future Care, but also as that sort of discharge activity translates to business as usual. So I think you can see that the joint working, if not the Future Care element, is really working well in getting those numbers and getting those sort of people outcomes into a much better place. I think the sort of second reflection with that is that as part of that planning, some additional P1 capacity was commissioned by health partners, and some additional social care capacity was commissioned by BCP. And again, it's another example of the really, really good partnership that I think is been developed and sort of alongside or as part of the programme, which has helped to hopefully deliver a better winter for Dorset residents than would have been the case prior to the programme. So I think the experience is a positive and tangible.
Okay, thanks for that, Dylan. Yeah, I suppose my question I had, and it was a bit looking at that chart, obviously for UHD, and obviously winter pressures are having some impact on that. Just around, I think, Dorset County Hospital, numbers are coming down probably a bit more consistently. Is that just to understand the sort of your take on the differences between the east of the county and Dorset County Hospital, so between the UHD, that might sort of help to explain those charts?
So I think there are 2 things. Well, no, there are 3 things that are different about the 2. So first of all, the work around transfer of care processes and the transfer of care hub started earlier within DCH than at UHD. And broadly speaking, they were through the programme, they're sort of 6 to 8 weeks ahead. And what we see in DCH, generally speaking, we begin to see it in a sort of larger scale at UHD. And so it's right that DCH are sort of currently in a sort of better position. We can expect that to follow in UHD in due course. I think the second thing about DCH and why there's specifically been success in DCH is in terms of the sort of numbers of team and the numbers of patients, it's smaller, and so it's been easier to embed the changes within DCH. and what we're doing to ensure that we achieve the same thing within UHD and within the East is we're targeting much more of our programme, and in particular our Newton resource in UHD hospitals and within the East through January, February and March. And so if you were to look at the sort of Newton team and how we're allocating that resource within the next 3 months, probably around 75% of that resource is now focused on UHD and the East. And so the learning and the experience from DCH we're sort of transferring to UHD, but also the capacity and the people that have developed that sort of knowledge of Dorset is also now primarily focused in the East. And so where we are as a programme is what has been delivered within DCH, we expect within the next period to follow within UHD.
Okay, thanks for that. Any other comments, Betty? Did you want to?
Yeah, I think just finally for me, I think it's difficult when you look at Dorset County Hospital and then you look at UHD, University Hospitals, Dorset, and you can't really compare them. You can compare them to an extent, but you can't overly compare them because you have, the makeup of BCP Council's footprint is very different to the area where Dorset County Hospital sit. And the number of beds are incredibly different. There's a much smaller number at Dorset County Hospital to what there is across the sites of University Hospital Dorset. And I think also all of the impacts that come from the type of areas that we are, and I know you know this, Chair, we get a lot more people that maybe we have to do mental health act assessments on who come down to our area, who maybe don't reside in our area but decide they're going to stay because of the nature of it and the attraction to it. When people come down in the summer, I might decide to stay and need care and support and all that kind of stuff. And I think also just, we need to be really mindful of the hospital, the new hospital model for University Hospital Dorset, and that is going on as you know, and our chair Voness, who sitting behind me, we went and had a look at that, didn't we? And we did all that. So there's so many other factors that need to be taken into account. You cannot look at them like for like. You can look at some of the principles and the guiding principles and what you're trying to do, and then how do you do that per head of the population in the different areas. But they are so chalk and cheese in many respects. I've worked in both and they really are very drastically different in many ways as well. Thank you.
Okay. Thanks for that. Any other comments or questions? No. The only other comment I was going to make is I don't know whether others had seen the BBC News in-depth item that was, I think it was released about midnight because I was up till about 1 o'clock last night and saw it popped up on my phone and was sat there about 1 o'clock this morning reading it, and it was all about this, about why the NHS spends so many billions on people that could be discharged. And having read through it, it's very much about, actually in certain areas there was very close partnership working between social care and NHS, and it's working well, but then there's other areas where there isn't necessarily close partnership working, and there's a bit of distrust, and that's where it sort of makes it difficult. So I think just on the basis of that, and I know we've sort of got good partnership working going on here on this programme, that sort of, for me, that sort of bodes well for the future, really. Okay, the recommendations before us are to recognise the progress that the programme continues to make in respect of improved outcomes for people and the delivery of financial benefits across the integrated care system, and noting the more work that's required to reduce the average length of time people spend in hospital waiting for a care package. So if everybody's happy for us to note those recommendations. Okay, thanks very much, Dylan. That's really useful sort of catch up sort of mid-programme, and I'm sure I'll be speaking to you and seeing you again soon as we go
Sure you will.
this year.
Thanks all.
Thank you very much. Agenda item 8 then, one of our regular items at most meetings, Better Care Fund. for the Q2 report for 2025-26. So Scott, our Better Care Fund Commissioning Manager, if you want to present this item. Thanks.
Thank you, Chair. Hi, everyone. I'm Scott Sathin. I'll be presenting the Better Care Fund 25-26 Q2 report today. And we've also got Jenny Crawshaw from NHS Dorset joining us as well, who will go through some of the more hospital data that will come up today. So, an introduction. So, in the Better Care Fund Q2 report, we had to provide details into the national conditions, our performance in Q2 that was set in the plans that was approved by the Health and Wellbeing Board in March last year, and the expenditure of the Better Care Fund between April and September of last year. The data was collected with scheme leads, members of the ICB, and our system partners as well. And this report was submitted to Better Care England on November 11th, 2025. And we had a meeting with the Southwest leads with the ICB in December to discuss intermediate care capacity and demand as well. So in the national conditions, we had to set out that we've got a Section 75 agreement in place for 25-26. It's been signed by BCP Council. And we had to also confirm that we are continuing with the national conditions that were set, which are making sure the plans are jointly agreed. We're implementing the objectives of the Better Care Fund, as well as still complying with the grant and funding conditions. And then we're also still continuing with the oversight and support processes of those schemes. And then we'll just go through some of the metrics. I'm going to pass over to Jenny for this point to go through the first two hospital-related ones. So Jenny, over to you, please.
Yeah, hi. As Betty and Dylan have already alluded to, we've started the winter this last financial year actually quite early. So our demand that we saw at the front door of our acutes was actually quite high. Just as a bit of a background, when we set the targets for BCF this financial year, we aligned that to the future care benefits that we were expecting to see this year also. So they were quite ambitious, as Betty's already alluded to. Despite the increased demand, I think we held quite well. Even though we were off target, I think without the work from Future Care, we'd have been in a very different, worse position at our front door, particularly with and our emergency admissions. In terms of discharge delay, we held really quite well in Q2. However, we're now starting to see the impact of that early start into winter in Q3, and that will be reflected into the next report. Again, quite a challenged winter we're having this time around, but I think considering the work that we've put into place and the ambitious targets that we set ourselves, we've actually performed quite well. Thank you.
Thank you, Jenny. And I'll just go on to the residential admissions. So in Q2, we did have high demand during that quarter, but overall year to date, we're still at quite a good place. And we're hoping with the work with our other schemes, we'll continue to see that for the rest of the year as well. So we've had, in that quarter, we had 59 new housing adaptations completed through the Disabled Facilities Grant. And we also launched the Community Reablement Pilot. So in that space of September, 15 people had been referred to the service. And at the moment, we're working with the operations teams to make sure we increase referrals and to continue demonstrating the benefits of having that service. And I just wanted to provide an update onto the integrated community equipment service provider that occurred in Q2. So NRS was our previous provider, but in July we were notified that they were in a critical financial situation and insolvency was imminent. So the integrated community equipment team had to work with a new provider, Mediquip, to make sure that once that happened, it was a smooth transition to try and avoid any interruptions of the service. So on August 1st, NRS did enter insolvency and Mediquip picked it up straight away. And they transferred staff over through 2P to make sure there was minimum job losses and that they did manage to continue the services, prioritising admission and avoidance and hospital discharge. And recently, sort of towards the end of Q3, they were getting their catalogue fully up and running again. And during that time, we didn't notice too much impact in terms of hospital discharges or other service interruptions due to that change. So I think, you know, we can thank the hard work that happened to make that as smooth as possible. And then we'll just quickly go through the expenditure during, so this is year to date, April to September. So it's roughly about 49% of the total spend of the budget, so 39 million against 79 million. Spending in Q2 was very similar to Q1. We are expecting in Q3 will reflect some changes due to the changes in the bed-based intermediate care service at Figbury Lodge. But currently all schemes are expected to spend on track. And then looking ahead, so we are still awaiting national guidance from Department of Health and Social Care to steer our plans for the Better Care Fund when we go into 26-27. Though the allocations for the integrated care boards have been published, so we do know that their contributions to adult social care services will have an uplift of 4.4%, while the discharge fund and other contributions will see an uplift of 2.1%. The local authority Better Care grant is remaining at 16.6 million, so that will be the same as it was in 24-25 as well as 25-26. And then at the next Health and Wellbeing Board, I will be presenting the Q3 report and a draft of the 26-27 plans to make sure you know what's happening for the next year. Thank you.
Okay. Thanks very much, Scott. Yeah, any questions or comments for Scott? Rob, did you want to?
Yeah, thanks, Scott, and thanks, Jenny. Really good report. I really enjoyed reading it. And great to see the performance is on target for some of the indicators. But of course, what I zoned in on was the emergency hospital admissions for people aged over 65. And my question, really thinking about it and with my public health hat on, is do we really understand the reasons for those hospital admissions in people age 65 plus? I know there's excellent work going on to avoid hospital admissions and to discharge people early. But do we, as a place, have an understanding of what the reasons are for those admissions, and are we doing enough prevention work upstream in relation to that? And I guess my mind kind of went to, we know from our joint strategic needs assessment that we've got high hospital admissions related to falls in people aged over 65, and we also have above average admissions in relations to drugs and alcohol. And I'm wondering, to what extent are we kind of looking at that data as a system and making sure that we've got some of those preventative services in place? So we're not just dealing with people once they're in hospital and turning them around and supporting them to leave in a timely way, but actually doing some of the prevention work earlier as well to prevent the need for admissions. Thanks. And also to say, you know, my team can help with some of that work too. So, you know, we'd be very keen to work with you to look at that data if there's a need to do that. Thank you.
So in terms of, sorry.
That's right, Jenny, go ahead. Yeah.
Okay, yeah, in terms of what we've seen, I've spent a couple of days in EDs over the course of September through to November, looking very much at the why are people attending and what is the need for admitting them. And just to give you a bit of an understanding of what we've been doing through Future Care, we have two front door models, one over at Dorset County and one over at UHD. They're both very different in nature in terms of how that's delivered. But through September, actually October and November, we saw some really poorly people going into the EDs. And we spent some time in there with Dorset Healthcare looking at the types of patients that we could comfortably support out into the community. And that wasn't that possible. A lot of the people that we had going in at that time were for respiratory infections, needing either IV antibiotics, which could be managed out in the community, but what we couldn't cope with was the new requirement or new need of oxygen in the community. So there's kind of a stumbling block that we're looking at there. In terms of falls, that's a question I'll take back and answer next time if that's okay. That bit sits outside of my work remit at the moment, but I will go and get some answers. However, I do know that we are working really quite closely with Dorset Healthcare and UCR teams to manage falls in the community, and also our care home 24/7 support line who manages care home falls as well. Thank you.
Thanks for that. Any other questions? Betty, did you want to?
Yeah, just to add to what Jenny said. Hi, Jenny. I think there's a couple of things. If you take the first point around what are the reasons for people over 65 being admitted into hospital, and although we have lots of different programs, running alongside one another, be it Future Care or Fulfilled Lives or whatever program it will be, we do know the reasons why people come in, why people present to ED, and then why they are then either triaged back into the community with same day treatment that is provided via ED, or why they're admitted into hospitals. Everybody that comes in, they are given a reason as to why they've come in and a reason why they've been diagnosed. Is it somebody who's had a stroke, had a heart, a heart issue, had something else, or whatever that might be. So we are able to abstract information very clearly with our acute colleagues that tell us those definitions of why somebody's presented and then been admitted. I think one of the things for me is around how do we make sure that we have our prevention that is so pivotal to what we do in our communities, because if we don't have good preventative offers to prevent people turning up at the front door of ED, you've almost missed the boat to some extent once somebody presents at ED. So it is all around prevention. It's all around working with our primary care, working with our voluntary and community sectors, working with all of our resources, our district nurses, our social workers, our health and social care providers right across our communities. And it's about how we really embed prevention. And, Sina and her guys have done a big launch on the prevention strategy. They came here as well, I think at some point, or will come here. Today, there you go. So it's coming here today, all around that. And I think that if we really don't get better at prevention, we're always going to be being reactive to things. And we know that for every pound we spend, we have such a good outcome on that. But I think it is all about that. And I think just around the falls, Jenny, we have been an outlier in Dorset under falls for a good wee while now, and we've tried and tested lots of things, but the numbers are beginning to go in the right direction. But some of that again is around our demographic. Some of it is around what's our frailty offer, what's our frailty pathway, and what's our frailty offer in the communities. And how are we doing that with our over 75s teams and all that kind of stuff? So there's a lot of stuff going on. It's about how we all bring it together and then wrap prevention around all of that. Thank you.
Zena,
Sorry, without danger of repeating, obviously what Betty's just alluded to, just to really also give you reassurance, we do have a social worker present in ED. We have a home care team that's in there as well that can take people out very quickly and turn them around so they don't have to go into hospital. So there's a lot, and voluntary sector as well at that front door. So there's a lot of mechanisms already in place to turn people around so they don't end up in hospital. And again, it's about that information then is imparted to us as commissioners, which has obviously helped to inform the prevention strategy. So it sort of links up. So that's what we know now what we need to be commissioning in the future.
Okay, thanks. We'll go for Mark first.
Thank you. So I suppose just picking up on the prevention side of things, I think there's a need for us to join the dots on a number of different work programs, which I think people have talked about. So just thinking about the opportunities around the neighbourhood teams or integrated neighbourhood teams program, again, that will be looking at sort of identifying people that are at higher risk And it comes back to data again, which has been talked about in the future care. So we have got in Dorset, we're quite fortunate that we've got very good systems in place with the DICE, so that we're actually able to now start to sort of understand who are those people that potentially are at greater risk. So I think there's something around, actually, as Betty said, you know, we're missing the missed opportunities, making sure that we capture people and identify them before they end up at the hospital. So I think there's something around how we join that dot together with the neighbourhood teams programme of work. Thanks.
Rob, did you want to comment?
Yeah, I think, you know, great to hear that in relation to prevention. I was at a meeting on Friday with colleagues from UHD and also GPs representing the primary care networks across Dorset. And one of the things that they talked about was, and you know, almost at the other end, but the admissions to hospital for people in the last 12 months of their life, despite having advanced care plans in place that are saying that they actually don't want to be admitted into hospital, but often that feels like the right thing to do or the only decision to make at that time. So for me, just making that connection with also our end of life and palliative care strategy, the work that we're doing to increase the numbers of people that have those advanced care plans in place, but also making sure that the wishes of those people are known as well. So UHD particularly was saying that they see lots of people admitted in the last 12 months of their life. It's a frequent thing. Because there's almost that, there isn't that confidence to manage them in the community in accordance with the wishes, and often it ends up being the last place that people go. So let's think about that in the context of our prevention strategies as well. And I know it's something we're keen to support as part of the health and wellbeing strategy too.
Okay, thanks. Zena.
Yeah, it's like that sort of work is being already picked up, and I think we had a really good presentation at the Overview and Scrutiny at the end of last year. That work is being picked up by another programme that we're involved in, so we'll be addressing exactly what Rob's just alluded to. It's an issue.
Thank you. Any other points or comments for Scott or for Jenny? I've got a couple of points I wanted to make, and I don't know if Rob's been reading that BBC article or if the BBC have been speaking to Rob, because actually what you just said was they've got a whole section in that article I alluded to earlier about time to rethink end-of-life care, and about that whole, exactly that point about the number of sort of appointments, medical appointments people might have in their last year of care, and actually is that necessary, or is it just sometimes doctors and medical professionals being a bit, oh, we need to treat this, we need to treat that, and actually not thinking through more holistically about end-of-life care. So I think that is a big issue. My couple of points, I'm glad, Scott, that you mentioned about NRS and Mediquip and the work that went on there. And I know we've spoken about this before, but I think it is really important to note the sort of amount of work that went into managing that sort of enforced transition from one major provider to another. And I know it's still sort of working through, Mediquip has still got to get fully up to scale and get established in the area. But yeah, I think that the amount of work, unexpected work, I think particularly people sort of going above and beyond to make sure that happened. And it's that, I know I've said before, the fact that it wasn't spread all over the local media or regional media is testament to the fact that actually it was managed really well, and it was covered in regional television and stuff. But I know I don't think we were mentioned. So it was talking about lots of other local authorities where they were dealing with the failure of NRS and how they were managing to cope with that. So I think yes, it's not been easy, but I think there's a lot of other local authorities around the country that are struggling a lot more in terms of managing that. And actually over the Christmas period I visited a family member who was lying bedridden in an NRS bed, and hadn't been serviced like it should have been because NRS had failed, and so she had a discussion about that happening in their area. So my other point I wanted to raise was just about funding of the Better Care Fund, and we just spoke about it. And certainly following the local government financial settlement, the figures we've got so far are that the provisional settlement for 2026-27 coming up is a flat cash sort of, so the same £16.6 million in terms of a local authority better care fund. The information I've had at the moment, provisional for the years after that, is that that's looking at rolling into the revenue support grant. And I understand we're probably still waiting for total clarification about that. But my concern, and actually I was on a call last Thursday with some party colleagues who are portfolio holders around the country, and actually an MP and a Lord that speak on behalf of our party in Parliament about these matters. And we actually had a discussion there about what does this mean long term for the funding of the Better Care Fund if it is rolled into revenue support grant in 2027, 2028, and our revenue support grant is reducing as a local authority. What does that mean for our Better Care Fund element from that? Can we confidently sort of continue to fund this sort of work? And for me, if it is rolled within the RSJ revenue support grant and that's being reduced for us, that goes completely against the government's whole agenda about the 10-year plan and about shifting from sickness to prevention. If actually a lot of the stuff we're doing on prevention, we're effectively having money withdrawn from us for that, then that's a difficult issue. So yeah, just some clarification around that sort of funding, because actually we've got access potentially for people to ask questions of ministers around that area to make sure that they're not going ahead with this sort of local government finance settlement without realising the potential implications and contradictions with their own NHS 10-year plan. So
yes, in regards to 26-27, as I mentioned, that's cash flat for next year. Going forward for 27-28, unfortunately, we haven't had the details. We are waiting the guidance from Better Care England and Department of Health and Social Care to steer us where we go beyond that, because their plan is to give us, more than a 1-year plan each time. So hopefully there'll be clarification when that's eventually published.
okay. Betty, did you want to?
So I think your point about the revenue support grant is a valid point and is one that has been debated and talked about in different forums, certainly within forums that I've been in and within wider forums for directors of adult social services. Those conversations have been coming up and have been coming up quite a bit. So there is a lot of I don't know if anxiety is the right word, but there's definitely a lot of caution around what will come from within the guidance when we eventually get the guidance, and what will be within the BCF that is currently within the BCF, and more importantly, what may not be within the BCF that is currently within the BCF. So there is a lot of anticipation really around that. As I understand it, I have certainly seen stuff and shared stuff that has come down nationally around some of what it might look like. And as far as I'm aware, we probably do just need to check this, there will be an opportunity for us to feed more into the BCF and what it might, what will it actually finally look like. I think it's helpful to have a review, and it's helpful to have that debate and that dialogue, but what we need to be really putting forward is any detriment or anything that really causes us any concern about it, and that it does fit within the 10-year plan and those areas within the 10-year plan, because they need to kind of go hand in hand to some degree as well.
Yeah.
Thanks.
Tina.
Yeah. Some of the guidance I've read that it was moving into integrated neighbourhood teams, and the BCF will be rebranded to become part of a fund for that. That's what I've understood was going to go forward. So just don't know if that shed any light or made things more confusing.
No, and I think if there's going to be consultation, then certainly that's something we'll want to have a view on. So yeah, Karen.
And also to sort of not forget mental health in all of this, because there's a summit next week, Mental Health Discharge and Flow Summit. I received information about it today, so I think can't remember, it's about joining up the dots, making sure that we're it's often the same person, an older person, mental health. People live in that way, don't they? So there's a big summit at Upton House next week. I'm sure people being invited or going, or I'm sending my new deputy to that. For her. Thank you. Ooh.
Thanks for that. Right, there's no other comments in terms of the BCF. Need to, I've got recommendations in front of us that the Health and Wellbeing Board retrospectively approve the Better Care Fund for 2025-26 Q2 report. I think the report usefully outlined the options. The other option is we don't retrospectively approve it, which I wouldn't recommend. Okay, is everybody happy that we retrospectively approve that report? Yep, nods all round. Okay, thank you very much for that. Thank you, Scott. That's useful, and thank you, Jenny, for coming online. Thank you. Right, agenda item 9. We're slightly behind schedule at the moment, but so Integrated Care Board medium-term plan. So, Mark, I know there've been some conversations about, and I think Bex is online as well.
Yeah, so thanks, Chair. So Bex is going to take us through a slide set, really just setting out what the ICB's proposed commissioning plan is, and we're happy to take some questions at the end. It's still an iterative process and still being developed, but it really is just to give sight to the Health and Wellbeing Board of the work that's going on. Thanks. Bex, to you.
Hi, I can't see anybody anymore, but can you see my screen?
Yes, we can, yeah.
Brilliant, thank you. And thank you for the opportunity to present here today to you. I wanted just to share with you, as Mark said, sort of the national context around planning this year, because it has changed, but try and focus mainly on the developing 5-year commissioning plan. And as we go through my presentation, hopefully that you'll see that the 5-year plan itself will set out how we plan to deliver the 3 shifts. So we have that support for improvements in outcomes for the people who live in Dorset. And it will also work to align to the health refresh, health and wellbeing strategies and the forthcoming neighbourhood health plans. And it is based on the ICB's commission intentions, which have been developed based on the population health needs, which has been informed by both our population health management team and working with colleagues in public health. And as Mark's already mentioned, it is an iterative plan, so it will be further developed and refined as we move forward, particularly when we consider the changing structures within Integrated Care Board and the further prominence on place that we will need to see within the plan. So here you can see, as I said, sort of planning has changed this year. The planning guidance, if you haven't seen it, the link is here for you, and it was issued on the 24th of October, and it signalled a big shift away from the short-term operational planning that we've been known to do over many years to longer-term planning, which sort of supports that longer-term transformation and improvement in outcomes. As you will expect, though, within the planning guidance, there is still a strong focus on that long-term financial sustainability, but it also empowers ICBs, providers and our partners to integrate care around prevention and neighbourhood services, which obviously we've been talking about quite a bit today. This slide on illustration effectively shows you the alignment of the different plans that we need to produce as a system. So planning this year is still done on existing ICB footprints, recognising that we're still statutory bodies until we cluster. And we've been working closely with our cluster colleagues, however, to align both our commissioning intentions and our approach to engagement within our plans and any priorities where possible. Within the requirement, providers are also requested to set out clear, credible, integrated 5-year operational delivery plans that look at how they deliver both the commissioning plan and the neighbourhood health plans. And you'll see from this illustration here that all the plans should align and be informed by and inform each other. These narrative plans are also supported by a number of numerical templates, which are for finance, activity and workforce, which both the ICB and providers have to submit, and that's part of the standard planning processes. So in terms of the actual plan, what will it set out? Well, it will explain how we are going to improve population health and access to high quality services across Dorset as Commissioner, and it sets out the evidence base for this. And as I've already mentioned, we've worked with Public Health Dorset and our PHM team to understand not just the population health needs, but the current issues within our services to ensure that we consider both the quality and the performance of these as well as part of our plans. The plan will describe the new models of care, such as our integrated neighbourhood teams, our approach to sort of planned care at a place level, and urgent and emergency care services. But it'll also set out the investment for these programmes, which will be aligned to the 10-year health plan, and show how how we will align the funding and resources to improve both the outcomes for people and the values of services that we want to see. In addition to this, as commissioners, it will also set out the improvements that we need to make and the progress that we need to get to have those core capabilities to be strong strategic commissioners going forward. And as we've mentioned, the plan is iterative and it will be refreshed annually. So as things change, as things move forward, we'll be reflecting these within our plans. I won't go through this slide, but it simply shows you the context and the contents that we've got in our plans at the moment. And each of these sections, though, will link back to our 3 major shifts and our portfolios of work. So in developing our plan so far and recognising the current position with the ICBs merging, we've basically building on what we've already had in our joint forward plan and our transforming health services in Dorset interim plan. And as I've already mentioned, they're based on our commissioned intentions, which have been approved by board in December. We've also confirmed our approach to engagement, and in doing that, we have reviewed 38 insights reports using an AI tool, which we've summarised themes by the core 20+5, geography and volumes of responses. And then we are now entering our planned information events, which start today, and we're taking a USAID we are doing or we're planning to focus on, and which we're testing back with these groups of representatives from across our communities to make sure that our response, what we're planning on doing, still meets the identified need of the people of Dorset. And we will update our plans to reflect this. I just wanted to thank CAN for their support in setting up these events. And sort of finally, the next steps. So once we've completed the engagement activities, we're going to reflect these within our plans and understand and reflect the emerging neighbourhood teams, the neighbourhood plans, as well as their health and wellbeing strategies. We also need to reflect the outputs of the strategic review of clinical services that is underway at the moment, and then set out our financial plans over the next 5 years, which will also describe how we will how our funding will change to support the left shift over this period of time. Our plans are due back to NHS England on the 12th of February, so we're going to be taking those to our ICB board on the 10th of February for approval, and then we'll share our plans back with the Health and Wellbeing Board at your March meeting. And I'll stop there.
Great, thank you, Bex, for that sort of run through and update on where we are. Yeah, any questions or comments on that? Zena.
Yeah, thank you. Really interesting. Would be interested to understand there's sort of any consultation with the local authority on the plan, on the commissioning intentions.
I can't stop sharing at the moment. I don't know whether anybody can break the presentation down for me. So we haven't we haven't engaged as much as you would wanted to have done with the local authority due to the timings, but we have been sharing our draft plans at our ICB board and committees, and we are happy to share future versions and our commission intentions outside of the meeting.
Thanks. Any other comments, Betty?
Yeah, hi. Thank you for that. That was really good and really interesting. I think I think for me, it is just about those connections with wider partners, and making sure that wider partners are part of that discussion, especially when we're moving into place-based in a really tangible way. And I'm just struggling a little bit if the consultation hasn't maybe been as pivotal or as robust. I don't know what the right word is. I'm not really sure, to be honest. But if it hasn't had that real engagement, I guess, from others, not just local authorities, I just don't want us to miss anything. I don't want us to kind of go ahead with a 5-year commissioning intentions that in 6 months' time or whatever we might think actually we've missed something. And I know that we're just establishing our ICB place-based director's post, particularly if I focus on the BCP area for that, I would see that is something that we would really want to pick up. And I don't know if I picked you up right or not, and I might not have, but where you said it was going for sign off in February, so maybe there's still some time to kind of get into the weeds of it a little bit with local authorities and with other partners. And if I just think about future care, which we're all signed up to, and which is one of the biggest transformation program that we're doing as a system, within that, there is a commission and work stream that's being led by David Freeman, and I would absolutely anticipate that work stream feeds into the wider commissioning intentions, and I'm not quite sure that that's happened yet. So it's just some suggestions really about what we could do possibly in the next month, or delay the signing off of it slightly, because I really don't want to kind of find ourselves in a situation where maybe we've been before. I don't know if that's helpful or unhelpful, but thank you.
Yeah, hi Betty, yeah, that's absolutely helpful. And we have engaged with obviously acute provider partners and others from across the system. I can assure you that the commission intentions do include INTs, future care, and all of those pieces of work, but there is more we can do outside, and we're happy to link in with you outside of the meeting.
Mark, did you want to come in?
I suppose just to add, really, I suppose one of the challenges we've had really is around some of the timescales against this, and obviously late guidance being published, which doesn't necessarily give you the right amount of time then to do the necessary engagement. So I think there is a little bit of sort of, I think there's engagement being done, and the intentions are based on the sort of needs that we understand. So Bex mentioned the health needs assessment, also the JSNA, the Joint Strategic Needs Assessment, will have been taken into account. So, but I do think that there's an opportunity for us to continue that dialogue, and I suppose it's really important to remember it's not a fixed thing at the end. So there is always the sort of iterative nature of it, so it can be updated on an annual basis, and it will need to be updated on an annual basis. In terms of the timeframes, Betty, that you mentioned, I'm not sure there is any slippage on that, because I think it's directed by NHS England in terms of what we've got to submit, but Bex will correct me if I'm wrong. Thanks.
No, we do have to submit on the 12th, but we can share our intentions with you and see if you think we've missed anything in the short term. But as Mark said, we will continue this engagement as we go forward over the next 12 months. And as I said, reflect and change it every year.
Laura, did you indicate?
Yeah, thank you. I think that partly helped answer actually, Becky and Mark. I think if we could see the strategic commissioning intentions, for me, there's something about doing an alignment piece, isn't there, and a cross-check, because you might refer to future care programme, but it's what it says, and are the two documents speaking to each other, and are we saying the same thing effectively? So I think that would be really helpful, and we'd welcome that. I welcome it being part of an ongoing dialogue, because I see that as part of the strategic commissioning role that the ICB has, and obviously what the local authority already has as well. So I think there's definitely more of a join up that we could do there. And so maybe putting down some markers, recognising you need to sign off on the 10th of February, but I'm sure that we can put some intentions in there around that joint working arrangement. And then just finally, I think the big one for me is the integrated neighbourhood teams, which are part of neighbourhood plans, but not the whole thing. So I think it would be really helpful if we just got together and jointly thought about how far have we got with integrated neighbourhood teams, how far does that get us? So to the points that we talked about earlier, is frailty one of the areas that we're prioritising in terms of an integrated neighbourhood team? But more broadly, how does that then fit with the neighbourhood plan and how we develop that. And I know we reference it in the health and wellbeing strategy, which we'll look at in a bit. But my understanding is that those neighbourhood plans, first draft is March 2026, answering quite a narrow scope, which, if you don't mind me saying, having been in the NHS, it's very NHS and health focused in terms of guidance. So it might be again that we just want to put some markers down about that joint working moving forward. So I think there's more to do, but there's something that we can do in the immediacy, as Betty has outlined. Thank you.
Thanks for that. That's useful. Any other comments or questions? Yeah, Karen, did you want to?
From a CAN point of view, we were asked last week to do this, and we've stood up over the weekend to support, and it's changed twice what we were being asked to do. And I'm not blaming my lovely NHS colleagues for that. I think the NHS England are driving this and driving, I can say this, can't I? They're driving, I'm going to say it anyway. The NHS England are driving the agenda, and our NHS colleagues are trying to make the best of what they're being asked to do. But I was quite surprised at how quickly, we can do it because we can, but it's been driven by NHS England, I think. And in my experience, because I've been at this for 150 years, is that when we try to do something so quickly, things do get, it's never great, is it? And I'm not criticising my local NHS colleagues at all. I think they're amazing. But when we try to do something quickly, that's when it doesn't work. And I will always say, and how are the council involved in this, as you all know? Sorry, but yeah, Saturday we were doing this.
Thanks for that, and for what you've done to sort of pull the stops out. To...
Oh, it's my wonderful team. I can't take kudos to that.
Okay. Right, and I know that's quite a sort of late agenda item we hadn't thrown on, but I think it's been a useful discussion and a useful airing of sort of where we are with the medium term plan. So thank you for coming along, Bex, and thank you, Mark, for that. And obviously you've heard the comments, and yeah, I'm sure the conversations will continue outside of here. So that was a useful item to have on. I think just to be able to air that. So thank you very much. Okay, swiftly move on, if it's okay, to agenda item 10, the update on the adult social care prevention strategy. So Emma, we've got you here to update us on this. Thank you.
Thank you. Yes, so I'm here to update on the adult social care prevention strategy, which is great, as there's been lots of comments on prevention so far today. So just to give you a bit of background first about why we needed the strategy, we were seeing rising demand and demographic trends. So with adult social care demand, support requests were rising 28% for ages 18 to 64 and 7% for those over the age of 65. And we're seeing an ageing population trend, with BCP Council residents over 65 expected to grow by 15% by 2028, making up 24% of the local population with extended years in ill health. And we know that living for longer doesn't necessarily mean living well for longer, because healthy life expectancy isn't increasing at the same rate as overall life expectancy. We also know that depression and anxiety are the lead disability causes among the 15 to 49 age group, and that accounts for 1/5 of disability in the BCP Council area. And the BCP resident survey found that 12% of residents felt isolated. And a recent meta-analysis of studies on loneliness and isolation showed that social isolation increases the risk of all-cause mortality by 35%. So we know that we needed to do something. And we really wanted to shift the focus to prevention as part of our adult social care transformation. So preventative services delay, reduce, or prevent the need for long-term care and support. And if we can ensure that the people of BCP live happier, healthier, and more independent lives as they age, it will reduce that increasing demand on our adult social care services. And the Local Government Association produced a report which showed that we can actually save £3.17 for every £1 spent on prevention. So in terms of our engagement for the strategy, We engage with our local communities, the local market, and our adult social care workforce. In March, we brought the voluntary and community sector and our ICS partners together to celebrate best practice, and we hosted workshops to explore key questions about prevention at our multi-partner prevention event. We had over 113 attendees. We also had 180 responses to the combined surveys that we sent out, and we gave over 30 presentations at different events, team meetings and conferences. We met with over 30 different voluntary and community sector organisations and community groups. So in total, we had a combination of over 400 people that attended our various events. And as a result of that, we came up with a collective definition of prevention that everybody agreed with. So that is that prevention in adult social care, it means taking early, proactive steps to help people stay healthy, independent and safe for as long as possible. It really focuses on supporting well-being, reducing risks and avoiding crisis by providing timely information, practical support and community-based services. By working together with individuals, carers and partners, adult social care helps people to make informed choices, stay connected and live well at home, reducing the need for hospital stays or long-term care. And through all of that engagement, we developed these 5 priorities of our prevention strategy. I'll go through each one, but I wanted to show you this diagram because it shows that we have people, carers and the community at the heart. Our first priority is a change in culture, with 4 different focus areas. The first one being strength-based and holistic approaches, so which really sits well with our Fulfilled Lives programme and our 3 conversations approach. Equality and diversity to make sure that we're inclusive and supportive for everybody. Co-production, making sure that we're creating those opportunities for people to support the development of our initiatives. And language and listening to foster that more inclusive and supportive environment by making sure that we're using that empowering language and addressing issues that create barriers to access. Our second priority is living and ageing well, with focuses on falls prevention, strength and balance, better physical health and promoting physical activity in adult social care to improve health and well-being, financial stability and security, working alongside our communities teams to make sure people have financial assistance and advice, and age-friendly communities, so we'll continue to work in partnership with our age-friendly network. Priority 3 is the individual resilience to build well-being. So we really want to empower people to take their health and their well-being into their own hands. And we'll do that by providing information, advice, guidance and self-education. We'll support people with sight and hearing loss. We'll also look at hoarding and self-neglect because we can see that's been something over the last few years that's really been increasing. And we want to make sure that self-funders and people on the cusp of eligibility really have that good access to information and advice early. We also want to make sure we support carers because we know the impact that carers have on our economy and providing support. Also occupational therapy and care technology. Our 4th priority is supporting the workforce. We want to really make sure that we strengthen workforce wellbeing in adult social care because if we've got a resilient, motivated and high-performing workforce, we know that we can really deliver preventative high-quality support. So we'll make sure that we develop staff and provide training so that they feel really confident in providing preventative support. We'll make sure there's that leadership commitment as well that's really promoting that culture of continuous learning and driving that delivery of preventative person-centred care. And we want to embed a prevention-first mindset across the workforce, so they first think prevention. And finally, in this section, we want to strengthen the workforce capacity for prevention by making sure we foster integrated, collaborative and communicative partnerships across health, social care and the community sector. Our final priority is connecting communities. So this one really is all about strengthening that connection and sense of belonging in people, trying to reduce loneliness and isolation. We also want to try and address health and social inequalities by strengthening those community connections and improving access for people. We want that community first mindset to try and help people to live at home for longer by prioritising community-based, person-centred support, which will help to avoid admissions, delayed discharges, and that reliance on long-term care. We also want to promote safer and more secure communities by helping to raise awareness of personal and digital safety. And we want to support the voluntary and community sector as well, because if we can make sure we can embed supportive commissioning practices and promote collaborative relationships, we can make sure that sector can thrive, because they're a real key partner in prevention and wellbeing. So our strategy was approved at Cabinet on the 29th of October last year, with a total annual funding commitment of 817,000. And since then, we've been working on our implementation. So I just wanted to give you a few quick updates on what we've been doing. So we're currently looking at our existing preventative contracts and either renewing or remodelling those to make sure that they fit with the strategy. We're going to start up some Connect and Collaborate forums, which will bring the voluntary and community sector together, adult social care commissioning and adult social care operations staff, to make sure that we're all working together in a collaborative forum. And we're also looking at a public health grants investment, and we're looking to target that towards improving physical health, falls prevention, and upskilling our workforce. And we're also working with data from the Dorset Insight and Intelligence Service, DICE, because there's some really good data coming out of that, where we can look at where we can target interventions, particularly looking at falls, if we can find out where people are, or people that have those factors that might increase the likelihood of falls. If we can put our interventions in place there, we can stop them falling in the first place. So just a quick update really on where we are, and over to our questions.
Thank you very much for that, Emma. Any questions? I've got some comments about Laura.
Yeah, well, first of all, I just really commend all the work that's gone on in this, and I said to Zena earlier, actually, just the nature and the format of the strategy and just how accessible it is, I just really welcome. I think it's so clear and it's brilliant. The work that's gone into it, I don't underestimate. I think for me, that the bits that you were just saying there about how we're looking at reviewing and renewing preventative contracts, there's something about the join up, isn't there? And I'm sure we're already doing it, but how does that align with Better Care Fund? How does that align with what we're doing with the ICB and those commissioning intentions? So I think it just picks up on the last discussion we had, really, and that would be really great to see, I think. So yeah, just a huge well done to the teams on this from me.
Sandra.
Yes, thank you for that. Yeah, actually took the words right out of my mouth. I was going to say how good this report was. It is just makes everything so clear. Everybody, you can't say that this is going to be another document that's on the shelf. The strategy is just so good and so useful, and it's so clear what improvements and what actions are expected to see. So, well done. It's really good.
Thank you. Karen.
Ditto. And also, will some of this come to the Health and Wellbeing Board to check in on how some of this prevention work is doing? Because I think it would be nice, because there's some really excellent objectives here, especially obviously for me around voluntary sector and community, and making sure that that's strong. It would be good to have. I'm not sure how that's going to come to this. Is it going to come through here?
Yeah, I mean, there's two platforms we would like. Rather than setting up another governance group, another governance board for prevention, we thought it'd be ideal if we could go back to ONS, over in scrutiny, and come here as a governance for that strategy, if that was going to be one of the asks, if that's okay.
That's okay with me as chair of the Health and Wellbeing Board, so that's one ticked off. Yeah, and I'm sure same with the ONS. Any other comments? Aidan.
Thanks. I just make a quick comment. It's probably on your final bullet point, Emma, about using the DICE information that we've got available. So a sense of moving into sort of predictive analytics. Was it that sense of we've got some really rich data, and it's taken a lot of time and hard work to bring that data together, and now we've really got to use it in a totally predictive way to and falls prevention was the example, wasn't it? So just say I'm really, that's exciting stuff, isn't it? It's not every local authority, not every system is able to do that. So it's something we should watch and encourage and support as best we can. So well done.
Okay, Stephen.
It's actually very timely because I had a call with them this morning just around people that self-fund their care and how they can drill down to the data and the populations and the areas. It's really sophisticated, and it's a great tool for commissioners.
Great, thank you. Any other comments or questions? Rob, did you want to?
Yeah, just to congratulate colleagues on a really good strategy, and to say that Public Health have been involved in the development of the strategy, and we're really keen to support the delivery of the strategy going forward, including some of the funding that you mentioned earlier, Emma. One of the things that struck me when I read the strategy again in preparation for today was the actions around co-production. And I know that our adult social care has a co-production strategy, but also just mindful of the co-production work that is now happening in the neighbourhood health programme space, and just thinking of the opportunities actually to join some of that co-production work up within our local place as well. So happy to work with you and to think about how we do that together as well going forward.
No other comments. I've got a couple of comments to make on this, not surprisingly, because we've spoken a lot about this whole adult social care prevention strategy as it's sort of moved through last year. I mean, for me, the whole process to developing it, and I attended the conference we had early last year with lots of representatives, and there was a real feeling in the room. People were behind this and wanting to sort of push this forward, and I think already a lot of people do a lot of prevention work, but it's sort of part of the job, and this is really pulling that together and actually doing it strategically and thinking about it and having a plan for making sure we're making the most of it. So that was really useful, and I think it also highlights the value of overview and scrutiny, because I know it went quite a long detailed presentation and discussion at the Health and Adult Social Care Overview and Scrutiny Committee, and they supported it. But at that point, there was the strategy and the plan and the report, but there wasn't necessarily the funding or the financial consequences identified with that. And it was only then, after Overview and Scrutiny supported it, that then over the subsequent weeks, I know there was a lot of discussions and conversations with finance, and figures were starting to be put together to actually then get the proposal together and effectively the sort of the financial plan to actually say, well, we want to go ahead with this, we want to deliver this, but this is what we're going to need, and this is how it needs to be structured. And it was really useful when I took that to cabinet colleagues, that we had the stories of difference, effectively, those real case studies of this is what it can mean. So certainly my cabinet colleagues that could read the strategy and plan, but it was only when they realised that actually they had residents in their wards that were using the handy van service or they received the different sorts of support that they could really sort of point to the difference it made in people's lives. And for me, this is one of those real useful cases of where the needs of our residents, whether they realise it or not, they need to, we need to help sort of prevent them sort of going into sort of long-term care and actually being more independent. And they know that for most people I meet, they'd rather be more independent at home and get the support that they need. It's where the needs of our residents really align with our council priorities and with the needs of the council financially. So in some ways, it's quite an easy sell to cabinet that actually your residents are going to like this. This is the sort of stuff that's really going to help them in their lives. But actually, it's also going to help our finances, because we know it's not sustainable for us to just say, oh, well, actually, we'll get a care home placement for you. It's much better to say, actually, we can support you at home and continue to live more independently, as an example. So it was one of those cases where everything aligns nicely. So I'm glad that sort of cabinet could see that and approved it. And I made sure to tell CQC that when I met with the inspectors the other week, and we were discussing about how cabinet and the Overview and Scrutiny Committee and everybody works together. So so yeah, I think it's one of those really useful cases, and I'm quite excited to see sort of where we go and as the sort of implementation sort of builds up pace. So great. Okay, Betty, did you want to add?
Yeah, I think this is brilliant, Emma. You know that we've had those conversations, but I think I would just finish on, if we don't do prevention, we aren't going to continue to provide the amount of services that we currently provide in the way that we provide them. We have to get a lot more robust at helping people become more independent, and we need to become better at getting to people earlier than what we're getting to them, because if we don't, we will not be able to sustain the levels that we are now in what we're providing. So it isn't something that we should think about doing. It is something that we absolutely need to support, and everybody needs to get behind it. So it's really good that we've got this and that we've got the funding that's been agreed to support it as well. Thanks.
And just as a final bit, it's come from an adult social care perspective, but it has so many ramifications for other parts of the council, because particularly the last bit talking about strengthening our communities and dealing with isolation and addressing that. Yes, it helps adult social care, but there's so many other parts of the council that actually that supports and helps actually by strengthening our community, strengthening our voluntary sector, making sure that people have access to sort of contact and the local support really is benefits so many different areas, not just adult social care. So great, thank you for that. Don't think that there wasn't. I think it was just for us to note that, wasn't it? I'll just check my notes. Yeah, so I think we're all happy to note the report and the work that's gone into getting to this stage. Agenda item 11 then, the health and wellbeing draft strategy for consultation. So Rob, I know you've been working hard on this, if you want to.
Thank you, Chair. So don't have a presentation to share, but I'll talk you through the executive summary of the report. And I know the Health and Wellbeing Board, we had a workshop where we looked in detail at the Health and Wellbeing strategy at the end of November. So the purpose of the report today is really to provide an update on the development of the Health and Wellbeing strategy. And also you'll find at Appendix 1 an updated draft of the Joint Health and Wellbeing strategy. And what we're seeking today is approval to now start public consultation on the draft strategy as well. And also to share our joint strategic needs assessment forward plan. So we presented the 2025 JSNA update at the Health and Wellbeing workshop, and we also asked Health and Wellbeing Board members to identify priorities for joint strategic needs assessments going forward too, and that's attached to Appendix 2. So board members will be aware that it is a statutory requirement for health and wellbeing boards to develop a joint local health and wellbeing strategy. And our previous health and wellbeing strategy ran from 2020 to 2023. And since that time, the Health and Wellbeing Board has been working on the development of a revised list of strategic priorities, which we presented here before, which were agreed by the board in January 2025. Over the summer, we undertook some detailed mapping of the work that is already taking place around these priorities, and then a draft health and wellbeing strategy was presented to the Health and Wellbeing Board on the 6th of October. We then held the workshop on the 24th of November, which included a presentation of the latest Joint Strategic Needs Assessment and the development of priorities for the JSNA Forward Plan. And then board members were asked to review and agree the draft health and wellbeing strategy, strategic priorities and proposed actions prior to a potential public consultation. And the feedback and the outputs from that workshop have now been reviewed, and a second version of the draft health and wellbeing strategy is attached to Appendix 1 in response to the feedback we've received. And the report also includes a summary of the key changes that have been made to the draft following the workshop in November, and they're detailed in section 3. Also wanted the board to note that there is a new requirement, which we've heard from the presentation on the medium-term plan, for a neighbourhood health plan to be approved by the Health and Wellbeing by the end of March 2026. And that will set out how the NHS, local authority and other organisations will work together to design and deliver neighbourhood health services. And we're expecting further guidance that will support the development of the neighbourhood health plan, which is expected this month. And then we'll be looking to bring that neighbourhood health plan to the Health and Wellbeing Board, hopefully in March for approval. And it is envisaged that the neighbourhood health plan will build on the health and wellbeing strategy. So it won't replace the health and wellbeing strategy, but it could potentially be seen as an appendix to the health and wellbeing strategy going forward. So the draft health and wellbeing strategy is attached at Appendix 1. It's been developed based upon the work outlined in sections 1 to 5. And board members are asked to approve the draft strategy now for public consultation. And that will be with a view to a final draft being presented to the Health and Wellbeing Board following that public consultation. We expect the public health consultation, if approved, will last for a minimum of 6 weeks. So potentially we may not be able to bring it back in March, and we may need to look at bringing the health and wellbeing strategy for approval back to the board at the following meeting in June. The board is also asked to note the suggested priority topics for the JSNA Forward Plan at Appendix 2 and provide any additional comments, noting that the Forward Plan is flexible and will be kept under review in response to local needs and priorities. And the board is also asked to note the new requirements to develop a neighbourhood health plan by the end of March. I'm happy to answer any questions. Thank you.
Right. Thanks for that, Rob, and thanks for Kat, I know is online as well, and Mark, I know you've had a lot of involvement in moving this forward. Comments and questions, Sandra?
Yeah, thank you, Chair. Well, can I just say first that I did enjoy going to that workshop. I'm quite happy to go to more of yours. They're quite good. I thought it was actually really quite useful. And yes, I am happy to support the updated draft of the health and wellbeing strategy. But I'm just asking questions about the consultation, because consultations that the council does makes me nervous for political reasons. And I don't know how you were going to do the consultation. Was you going to go on the website and that sort of thing? It's just that it does make me nervous because it does get hijacked now and again by time wasters. But I expect you know all that. And I just think it needs a good press release to go out with it. Thank you.
Rob, did you want to?
Yeah, so we're working with the council's research and engagement team on that at the moment. So I've given them a set of draft consultation questions. We've got a new digital platform that we're hoping to use to run the consultation on. I think we've got about 4,000 residents that are registered to receive consultations too. So that will be our primary route of consultation. We do also want to engage with key stakeholders too, so really keen to work with our partners like CAN and other strategic partners, and to take the strategy out and to talk to people about it too. It is a 5-year strategy, so it's important, I think, that we listen to the views of our key stakeholders and to local residents as well. But appreciate the concerns raised.
Thanks. Yeah, Kat, did you want to come in on that?
I think Rob stole most of what I was going to say, but it was just to reiterate that it'll be the sort of the formal public consultation that we do online to make sure we gather those, but absolutely taking on board Councillor Moore's viewpoints about making sure it's not hijacked. So we'll be using all of our trusted voices, our community champions. So we'll be going out to the Access to Food Partnership, our age-friendly communities, our community development officers. Obviously, we'll be asking CAN to support us. I know Karen's already given us an offer that she'll support it through her network. So going out to as many as our trusted locations to try and get feedback. And feedback will not have to be just on a standard form. If someone just wants to sit down and talk with us, with our officers about what they think about it, equally we'll be able to gather that feedback and that information and feed that back in as part of the consultation process.
Thank you, Kat. I think, and my comment on that would be, I know there's certain political hot topics. I think that when they go out to consultation, you have to be wary because there are sort of certain people or interest groups that will hijack things and make a big issue about them. I think probably the health and wellbeing strategy for me isn't a sort of sensitive political area that I think those groups would pick up. And actually, I think having a consultation is probably a good opportunity to actually talk to people about the fact that as a council we do health and wellbeing. You know, there's still a lot of people out there that moan about the roads and bin emptying and that, and don't realise that the council do health and wellbeing as well, and actually we've got a really big part to play in that. So I think in some ways that actually this is a good opportunity just to sort of bang that drum and get the message out, and maybe raise a few eyebrows among some of those sort of people that want to moan about 20-mile-an-hour zones and potholes and things, but to realise that we actually, yeah, we do something that can really impact theirs and their families' lives. So any other comments or questions on the strategy as drafted? I think the lack of questions is probably an endorsement of the work that's gone into it, and the work that went onto it, the workshop. I know there were some really useful discussions we had at the workshop, certainly that I was involved in. I'm sure everybody was involved in it at that workshop. So thank you for sort of taking those discussions on board and working it through into this structured draft strategy ready for consultation with the public. So I think what we asked to, oh, this has got the longer recommendation, hasn't it? Recommended that the board note the progress made to date with the development of the draft strategy. We approve the draft strategy for public consultation. We note the new requirement to develop a neighbourhood health plan by the end of March 2026. I think that's one of the interesting wrinkles, isn't it? That we're developing the strategy that when there's been a lot of other moving parts in terms of government policy going on, and that we note the suggested priority topics for the Joint Strategic Needs Assessment Forward Plan, providing the additional comments. So is everybody content with those recommendations and happy to approve the draft strategy for public consultation particularly? Lots of nods, no shaking heads, good, excellent. Okay, I think we can take that as the green light to move on with the public consultation and go ahead. So thank you, Rob and Mark and Kat for the work you continue to do in terms of sort of pushing our strategy forward. So. Great. Final item on the agenda, well, just about final item on the agenda, final substantive item, item 12, health literacy update and proposal. Got Paul Iggulden here from one of our public health consultants. I can now say one of our public health consultants, because before you were our public health consultant. Actually, after the last few weeks, we've now got more than one, haven't we? So, yes, yeah. You've got some colleagues alongside you now. So, Paul, over to you. Yeah.
Is that better? Picking me up, okay?
Yeah.
Right, thank you. Hello, I'm Paul Iggulden, as the chair says, consultant in the Public Health and Communities team. There's a paper in the pack. Focus of that is recommendation for how we take forward organisational health literacy across BCP and Dorset. So I'll just draw out a couple of key points, if that's okay. The paper's quite brief and to the point, but if I could just highlight a couple of key areas. Firstly, what do we mean by organisational health literacy? We've been working to a model that sort of draws a distinction between the notion of personal and organisational health literacy. Personal health literacy being an individual's ability to understand and act on health information. Organisational health literacy being the degree to which the organisations equitably enable people to find, understand and act on information. So it's the emphasis there is on the organisation being clear in its communication, checking understanding and having accessible systems. In essence, organisational health literacy is the system's practical response to the variation that we see in personal health literacy. So is organisational health literacy an issue for us across BCP and Dorset? I think the evidence talks to it being so. Estimates suggest that 6 in 10 BCP residents, 6 out of every 10, have low health literacy or numeracy, which would limit their ability to find, understand and act on health information. So 6 in 10 are going to struggle to access our information and act upon it unless we take care to present that in an appropriate way. So all of the good work that has been talked about earlier on in the meeting around prevention, etc., it requires us to pay some attention to how we put our messages across to organisational health literacy. So we increasingly were referring to health literacy as being foundational. Prevention, patient activation, all of these other things that we're looking to achieve, which would help us to reduce health inequalities, really sit on top of sound health literacy. So just a little bit to say progress to date. We've been working on this agenda across the Dorset system through initially the ICS Health Inequalities Programme. The journey started with a series of webinars and symposium. Recently we've been putting in place training, awareness raising and champions level training. We have trained over 400 people to date and have about 50 health literacy champions in place across multiple organisations across the system. And the evaluation work that we've undertaken to date suggests improved awareness, communication skills, and intended changes in practice. I say intended, for some they're early on in their journey, for others, as the case studies to the report show, they're some way further down their road. So Community Action Network have one of our very active health literacy champions, and indeed CAN have done an awful lot of work around this agenda, and it underpins a lot of your policies and processes now. So following the disaggregation of Public Health Dorset, we're at a juncture that requires strategic decisions around how we scale and sustain the progress that we've made. So we're asking this board, and we'll be looking to do similar with the Dorset Health and Wellbeing Board and the System Executive Group. We're asking boards to nominate people leads, health inequality leads, to come to a workshop session with us to revisit the health literacy progress we've made, to explore the 5 elements that make up the health literate organisational model. And then equipped with that background, we'll be looking at working with the participants to help us co-produce an approach for how we scale up health literacy, organisational health literacy across BCP and Dorset. So Chair, asking really the board today to confirm health literacy as a partner priority and for partners to share with me some nominees to join the workshop I outlined.
Okay, thanks very much for that, Paul. That's really useful, actually. Any comments or proposals of people to get on board with that? Betty, did you
Hi, Paul. Hi. I think this is really, really important and long overdue. I'm just thinking about some groups of people that would that would really benefit more from us doing some focused work around health literacy. And I'm thinking around when co-production was something that came in my mind when I read this, and I'm interested to make sure that when we look at co-producing, that we have those the range of individuals that we work with to gauge their life experience and expertise in those areas. So right away, what strikes me is everyday members of our population, but also those in our population that need further assistance, such as those with a learning disability, with autism, or various things that they have to deal with every day. And I'm thinking about where you can really target is somewhere like our health, our LD partnership board, our learning disability and autism partnership board, where we have carers, it's co-chaired with people with lived expertise, and it's also got all of those voluntary and community groups that wrap themselves around and support those groups of people. I think for me, it is very much around how we co-produce this. This is not something that we should come with a blueprint or a draft. We should really do this from the beginning, because we continue in our in our areas of practice to continue to use acronyms, to use jargon, to use, never mind understanding it. Some people don't even know what it stands for. You know, so we need to really consciously have that embedded within everything that we do. And I think we can really learn a lot from this. We'll start with health literacy, and then I'm sure we'll go into lots of other areas of literacy. So I see this as a really valuable piece of work, and it's come at the right time because we really want to further empower our residents. And we need to give them the tools to be able to do that. And one of the main things is being able to understand and know what we're actually asking and asking of them. So I really support this, and I have somebody in mind who can really kind of help you with that. So if you want to drop me a note, thank you.
Okay, thanks, Richard. Next, and then.
Yes, thank you. Actually, it's quite fascinating, this, because I've just been spending some time looking at the map here of health literacy, and though it doesn't mention on the map health numeracy, but that also, I mean, it does in your report. You talked about the numbers. It's actually scary, actually, because BCP is actually better than national average, isn't it? And Dorset is better than that. And therefore, in some areas, it must be. You know, so we got something right. However, it's still quite scary, isn't it? Yeah, my thoughts, and this is slightly random, of course, you talk about 16 plus here. Of course, all pre-16s do health literacy and health numeracy to a large extent in the science curriculum and the PSHE curriculum. So I was just wondering, is there any looking into that? Because, of course, having consistency of terminology going through does help. And something which, of course, you didn't mention, of course, is commercial health literacy. Because I feel that that is an issue, because of course commercially a lot of people use deliberately confusing terminology to try to get people to sign up to buying things or not worrying about things, which I think is causes a lot of the population a problem. But it's really interesting. I'm going to reread some of this again later on and do a bit more delving into maps and things, which is.
Karen, did you want to?
It is really interesting, and once you start going into this, you never think about things the same way, by the way. And I think calling it health literacy, we've talked about this, haven't we, is a bit of a misnomer, really. It's just common sense, plain English, really, is what it is. Which is quite funny because the title of it is a bit of a misnomer, and we're trying to make it really plain. Sorry, I'm not. No, you know, we've talked about this, haven't we? But actually, you know, when we did the training, and some of my team have become champions and delivered the training, and it really does make you think about things as a professional and just as a person in a slightly different way, because we do have a language, a professional language, of course, but whether we like it or not, we do, and it can be quite excluding. And we've also worked through our Ethnically Diverse Communities project. We've worked with a lot of those communities to look at how they can better access information in a way that, not in a condescending way, but in a way that is best for them. Because if we get it right for everybody, we get it right for everybody, by the way. You don't have to have, oh, we'll have one over here for professional people and one over here. If you just have a really good thing that everyone understands, then that's all you need, really. But once you go down the road of it, it's really, I found it incredibly eye-opening. And we do try at CAN as well very much to embed it in everything. And we've got a champion who reminds me regularly, by the way. You can know who that is.
Thanks for that, Karen. Any other? Yeah, Rachel, did you want to?
I just wanted to add in that we've got a campaign in Children's Services, Language That Cares. So it would be really useful to link in with that campaign, which we launched in Children's Services in October. And we've just started to take it more widely now. So linking it and making sure it connects would be really, really helpful, I think, for our children and young people.
Yeah, thanks, Mark.
Yeah, really valuable feedback that we've received, and thank you, Paul, for pulling the report together great to hear about all the work that has been done today, and to hear particularly about the examples of the work and the difference that it has made with CAN. I think a really helpful challenge around children and young people, that we don't make that assumption that this is, although the data relates to adults, health literacy I think is broader than that, and we need to make sure that as we continue with our plans, particularly around neighbourhood health, and that shift from treatment to prevention, and also from analog to digital, that we don't leave some of our communities behind, where they're already struggling to understand some of the health information that we give them in person or in written form, and then we expect people to also be able to access services in a digital form as well. So there is quite a lot of discussion at the moment in the system around digital exclusion and digital health literacy, and what can we do to tackle those going forward. And I think making the links with the adult social care prevention strategy and the work that we're looking to do with the workforce to embed preventative approaches, I think it'd be really good to make that connection as well with health literacy and digital literacy too. So yeah, thank you for the feedback, and just keen to make those connections between the different programmes of work.
Thanks for that. That's a useful comment to make that link. Mark, did you want to?
Yeah, similar to what Rob was saying. I think it's great to see the report and see the sort of case studies coming through. And I think there is something around getting this as a foundation principle, isn't it, through all the pieces of work that we're doing. So we've talked about lots of different pieces of work today in the board. Actually, how do we embed this as a principle that we should be using throughout all the pieces of work that we do around transformation? And I see that the reference is made to the Integrated Neighbourhood Team programme on the paper. And that there is a real opportunity there, isn't there? I think if you can get into that co-production group to really hold that programme to account around making sure that what we're doing is going to be literate for people in their communities, and then tying that back to the development of the neighbourhood health plans as well, which will be coming on board. But welcome this, thank you.
Thanks for that. Did have from Lizzie at UHD Online did ask a quick question in the chat about is it just one person from each organisation?
No, would welcome those that would be relevant, have skills, expertise to offer. I would anticipate OD, people's leads, health inequalities might well be useful contributors, but yes, more than one's welcome. Thank you, Lizzie.
Thank you. I've got a few people I think would be interested.
Yeah. Okay. So I guess if people, well, sorry, I'm jumping ahead. You need to decide whether you agree or not.
Well, okay. The recommendations we've got before us are to confirm health literacy as a system priority. Can I take that as read? I think that from the comments that we've had that we agree that first recommendation. So then just to nominate leads to participate in a workshop as described there. So I think there's been a few people have thought of people that they want to suggest. So is it best to sort of email you, Paul, and then you can have those sort of conversations with people from whether it's internally within BCP or external partners as well to sort of, yeah. Okay. Thanks for that. It's really useful, and I did want to add, I know I sort of introduced you obviously as no longer just the public health consultant that we have within our public health team, but I know, Rob, we've had 3 new public health consultants join us in December and January now, so we're up to a full complement. So hopefully we'll be meeting some of those at future health and wellbeing board meetings as well. So, okay, great. Okay. Beyond that, then it's just agenda item 13, which is the work plan. So obviously it lists what we've covered today with the Health and Wellbeing Board. Then the next meeting on the 9th of March, again on the Health and Wellbeing Strategy, annual report of the Community Safety Partnership, Better Care Fund Q3, and then there are listed a few other items there. For potential future meetings, and Mark, I will endeavour to be there on the 9th of March as chair to chair the meeting. I don't want to throw you into that as the as the vice chair, so I'll make sure I'm fit and well on the 9th of March. yeah, any comments on the work plan? Betty, did you want to?
I'm just wondering, thinking of timelines, but noting my conversation with you just before committee started, or the board started,
Yes.
you might want to put CQC in there somewhere, or
Yeah.
our feedback and whatever in February or March.
Okay. Care Quality Commission assurance visits. I keep trying to make sure I call them assurance visits rather than inspections. Rob.
Yes, Chair, and also to note that we'll have the NHS Strategic Commissioning Plan to come back in March, and hopefully the Neighbourhood Health Plan as well. So if time could be allocated to those items as well, that would be really helpful.
Okay. Great. Okay. Any other points or comments on the work plan? No, I'll thank everybody for turning up. Apologies, 5 minutes beyond my expected time of completion, but yeah, I think there was some useful reports there. Thank you for all the preparation work everybody's put into preparing those reports and for your input and discussion. Thanks very much.